has worked in almost more hospitals and countries than I've even visited, let alone had a chance to have a job in. So 51 hospitals at last count. He's a professor of emergency medicine at Queen Mary University University of London, and part of Barts Health and part of the Barts Health Research Group. He's an incredibly accomplished man, and one of his passions is echo, and that's what he's going to talk to us about this morning.
That was echo, not ECMO. ECMO's a bit beyond me. Thank you for the introduction, and I apologise if I lose my voice. Local virus. So, yeah, I've not been anywhere near China, so I feel very safe. I'd like to talk to you. Oh, am I right to stand this side, or no, I'm not. I've got to stand this side. So I'd like to thank Daniel, Mads, organisers, for the invitation. I think this is the best conference of the year. It's the best because anyone of the audience could be up here talking, and we continue, we share things. And I learnt yesterday from Ross that most of the audience sit there wanting 5 points and are thinking about the next coffee break, and I'm sure there's truth and wisdom in that. But this is one of the few conferences I go to where I don't think that. I meet people that are passionate, that want to change the system, want to share their knowledge. So this is not a Ross compliant talk. It's probably the last non-Ross compliant talk I'll ever give, and I'd thank him for his wisdom yesterday. So, wow, I've gone backwards. Not for the first time in life. Am I on the wrong stick here? Yeah, definitely switched on. Let's just try switching it off and on. There we go. Foiling is a great sport. I've taken it up recently. I spend most of the time upside down, but it's good fun trying. And it's probably even more fun than skiing. I have one conflict of interest. A number of ultrasound manufacturers have given me machines to test, but I've never been paid to do so, paid to publish, or paid to go to conference. The aims of this talk is to convince those of you that are not using echo or are beginning to use echo that it's an easy tool to help you in resuscitation. This isn't a why use it talk. This is a talk based on the teaching I give to my juniors, and it's pitched at the person that's done a bit of training and is in the process of becoming confident and competent. And one of the key things we do with echo is determine left ventricular performance. It's the most common cause requested of cardiology, and it's arguably the most common cause for those of us that are interested in resuscitation. So we're going to talk about assessing left ventricular performance. And we're going to talk about some tips to try and give you confidence, and this is based on the workshops I run at various conferences and the support I give my trainees when they've jumped from I've been to a workshop, I can do it, but I haven't done this enough to feel confident in my findings. So that's who this talk is pitched at. We're going to ask ourselves 3 questions of the heart. Can it pump? Systolic function. Can it fill? Diastolic function. And do all the walls move the same? Are there any regional wall motion abnormalities that suggest ischemia? Last thing we're going to talk is, can we do this as non-cardiologists? So there's you. You are a critical care provider. You might be based in the ED, you might be based in ICU, you might be based pre-hospital. You've just met a paramedic crew. They've seen a man in his 50s, he works as a delivery driver. His friends noticed that he's not been quite right at work. He's had a cough, he's had a fever, he's had difficulty lifting some furniture. They went out, had a lot of beers last night, and he left early. His friends went this morning and they found him confused in bed and brought him to hospital. He was febrile, hypotensive and dyspneic. He received a litre of fluids from the ambulance, and he's yours to assess. What would you like to do? Yeah, I guess it's an easy answer, isn't it? Yeah, he's got a metabolic acidosis, and he needs further resuscitation, and the key really is, what's the driving process of his sepsis, and do I need to give him fluids? inotropes, pressors, or a mixture. And this is his heart. And you can see within a very short time his IVC is full. It's collapsing by less than a third. That suggests, it doesn't tell you he's not a fluid responder, but it makes it unlikely. You look at his lungs. Now he's got pneumonia in his right lower lobe, but when you put the ultrasound probe on, you can see B-lines all over his lung fields, because ultrasound is a much more sensitive test than chest x-ray for fluid. About a third of the people that have apparently a normal chest x-ray will have evidence of pulmonary edema, be it cardiac or non-cardiac. And you can see that he's got mitral regurgitation and a dilated poor ventricle. So within those 2 minutes, you know that this guy is probably at the end of Starling's curve. He's unlikely to benefit from fluids. He needs central access, inopressors, and a bed in very expensive care. So how ultrasound can help guide your therapy? You can identify patients that are more likely to be fluid responders. You can identify their fluid response. You can identify patients that have poorer reserve. This man clearly has very poor cardiorespiratory reserve. He's at high risk. He needs expert critical care involvement. You can predict a little bit how someone's going to respond to fluids. If you've got somebody that's got a stiff, hypertrophied ventricle, their compliance curve is likely to be very, very steep. And so that's why diastolic dysfunction is important to us in resuscitation as well as the etiology of shock. We've heard a lot of messages here. Fluids are bad or potentially bad, and we know that fluid overload in intensive care is associated with a number of poor outcomes: longer stay, more ARDS, more renal failure. And we've got two large trials, the FEAST trial, paediatrics, and this Andrews trial from Zambia, that suggest early dosing of fluid boluses may be harmful. Now both of these are African trials. It's difficult to know how they translate into Western practice. But if we look at this study, they looked really at either giving an accelerated fluid regime, and we're talking 4 litres in the first 6 hours, which, while it's a reasonable amount of fluid, would not be exceptional in any of our practices, although maybe getting more exceptional now. And this trial showed that patients that got the intervention, the higher dose of fluid, had around 3.6 litres of fluid, and those that had the conventional had about 2 litres of fluid. So only a litre and a half difference, but there was a significant mortality disadvantage. So we have a consistent message through the literature that we need to be more careful with fluids. And if we look back, echo and a lot of cardiac output devices have been used to target goal-directed therapy. We've been constantly saying, who's a fluid responder, give more, give more. I think we've got that the wrong way around. What we need to use these goals for is to identify the half to 2/3 of patients that are not fluid responders and stop doing something that's potentially dangerous. We need to turn that goal fluid on its head. And I think that's a key thing, a key role for echo, because you can do this very, very early on, pre-hospital or in the ED. In the next cubicle to our poor man with a poor heart was a very similar man, and he had a similar set of observations and a similar story. His IVC is collapsing almost completely. He had a hyperdynamic left ventricle. I left him with my resident. I was happy that initially we would give this guy some fluids, and indeed he had around 20 mils per kilo. He normalised, his acidosis corrected, he produced urine, and he went to the ward. But it was the use of echo that said, I'm going to leave you with my resident. I want to focus on the guy next door and talk to expensive care about him. That was the key determinant, not the figures, because the figures on the two in terms of acid-base disturbance, lactate, and blood pressure were very similar. So cardiologists use Stimson. They divide the left ventricle into these imaginary discs and work out ejection fraction, the proportion volume difference between end diastole and end systole. Elegant, accurate, no place for us. It takes time to do, it's fiddly, and actually I haven't got 5 or 10 minutes. I want to be able to get my echo done in a minute or two at most, because there are other patients to see and other things to do. So for us, the best way we can assess left ventricular performance is by eyeball. We look at the ventricle and we make a subjective assessment. And there's good data that if you've looked at several hundred echoes, that is the best way to assess ventricular performance. The problem is, and the purpose of this talk, what do you do when you're going for I've done a course and seen 5 to I've seen several hundred? Because as doctors, paramedics, nurses, we learn to quantify things. It's very hard for us to become comfortable in what is essentially a non-quantified estimation. So we're going to talk a little bit about how we can do this, which is using MAPSI, tissue Doppler and EPSS, which are terms I'm going to come and talk about in a moment. So EPSS, E-point septal separation. This is the distance between the anterior leaflet of the mitral valve at end diastole and the septal wall. As your ventricle sucks blood out of the atrium, it opens up the mitral valve. The more blood it sucks through, the more the mitral valve opens, the more it opens, the closer that leaflet goes to the septum, and that predicts left ventricular performance. Now you can use this formula to work it out, or you can just do the simple things and say, if the two are kissing, it's normal. If they're touching, it's normal. If it's between 7 and 18 millimeters, I've got moderate dysfunction. If it's more than 18 millimeters, I've got severe left ventricular dysfunction. And it's a reasonably good predictor. It's not as good as eyeball, but it helps you train your eye in those first few hundred scans. Now you can do this in B mode or M mode. B mode stands for brightness, and they're all the pretty echo pictures you're used to seeing. M mode looks at one point in time. Now traditionally when this was described about 30 years ago, it was based on M mode, but as time goes on, B mode pictures get better and better, and personally now I just don't worry about working out my E and my A wave and putting down my M mode cursor. I just measure it by freezing the picture and going through frame by frame until the septum and the anterior leaflet are as close as possible, and I measure that minimum distance. Second thing you can do is MAPSI, mitral annular plane systolic excursion. Here you're putting your M mode and you're looking at your cardiac skeleton. Here's your mitral, to measure the movement of part of that cardiac skeleton to and from the apex. And you're going to remember 6 and 12. 12 is normal, less than 6 is severely impaired. If you want to get a little bit more sophisticated, use tissue Doppler. Tissue Doppler is like pulse wave. It measures movement in one place, but here you're measuring movement of the wall, not the cells as they move through the chambers. And you get very, very pretty graphs. And so here is your baseline, here is your probe, here is your M mode cursor. And initially, of course, the cardiac skeleton, the annulus, moves towards the apex. That's systole, the S wave in contraction, and then it moves away as the ventricle falls, initially with the E wave as the passive filling occurs, and then with the A wave as the active filling occurs. E, early, A, atrial. And just remember 8 and 10, 8 and 10. The best is eyeball. By eyeball we mean you're looking at how that ventricle is performing and you're saying, do the two walls come together and make the chamber about 30% smaller? If they do more than 30%, it's normal. If they do less than 10%, it's severe dysfunction. So that's what you're looking for. Now this is best done in the parasternal long and short, because ultrasound works best where it cuts perpendicular to the point it's measuring. You can do it in the apical and subcostal views, but you are going to have a little bit less accuracy, a little bit less judgment. So best in the parasternal short and long, and you can see that's a hypertrophied ventricle, and this is a dilated systolic dysfunction ventricle, and you can see that's clearly moving by less than 10%. It's severe dysfunction. Regional wall motion abnormalities. Now, the heart should double in thickness. So the wall of the heart should double in thickness. If it increases by 10 to 50%, you've got a regional wall motion abnormality. Less than 10%, it's akinetic. Now, the heart always moves, so I find it easiest to put my pen in the middle. I've put an X in the middle here. Is each part of your wall coming towards that midpoint, and is it doubling in thickness, increasing by 50%? Yes, normal, 10 to 50% regional wall motion abnormality. Of course, it's much more complex than that. Now, cardiologists divide the heart up into regions and chambers, but that doesn't matter for us early on. And the single best point to do this is in the parasternal short axis view at the point of the pupillary muscles. And just remember their salpi. Septum, anterior, lateral, posterior and inferior walls, salpi. So here's the pupillary muscles, and those walls are the LAD, circumflex and RCA. And we saw that very early on in a talk on the first day. And you will see this wall become akinetic from a STEMI before you see your ECG changes. Diastole. If your heart can't fill, it can't pump. Filling is an active process. Think of diastolic dysfunction when you see hypertrophy. That's a septum more than 13 millimeters and a free wall more than 11 millimeters. It's all about pressure, and if you can't fill, you can't pump, and your compliance curve will be steep. So a small amount of fluid will give you a reasonably steep dose response, and it will be reasonably easy to push these patients into pulmonary edema, and of course they're very tachycardia sensitive. Now, our cardiologists grade diastolic 1 to 3. They look at a number of things. They look at tricuspid regurgitation, they look at ventricular filling, they look at tissue Doppler, and they come up with these wonderful complex graphs like this and this. Forget it. It's great in outpatients. I really don't think we need to do this in the back of an ambulance, in someone's house, or in the emergency department. We need to simplify it. Measure the atrium in the parasternal long or the apex, apical. If it is under 20 centimeters squared, you do not have diastolic dysfunction. So if you've got a normal atrium, for the purpose of your resuscitation, that's the cause of your dyspnea or the behaviour of your fluids, you do not have significant diastolic dysfunction. Add to that the tissue Doppler that we just talked about, measurement of movement of the wall. Two things for us: size of the atrium, movement of the wall with tissue Doppler. If you want to get a little bit more sophisticated, you can measure flow of blood through the mitral valve, and you can measure what we'll show you in a minute, the E wave, and then you've measured that tissue Doppler, your E prime, and the ratio of the two is approximately the same reading as you got from the Swan in your pulmonary artery occlusion pressure. Now, I grew up in a cardiac ICU, so Swan measurements made me feel secure and good. So when I started echo, I measured this a lot. I must say now I tend not to, because it rarely impacts my management, because I know what this is from this. So we're going to put our pulse wave gate. Pulse wave measures movement of blood at that point. We're watching how blood moves from the atria into the ventricle with early and atrial filling, the two phases of diastole, ventricular diastole. We're then going to move our cannula, our probe, and we're going to look at the annulus, lateral and septal wall, and we're going to put on tissue Doppler, which is just a modified pulse wave, and we're going to measure movement of the annulus. The S mentioned earlier, we've got the E and the E prime, E prime and A prime, which is the movement of the walls. We're then going to move the septum, move the cursor to the septum, and do the same thing over the septal wall. And the figures to remember is your E prime, that's the movement of your septum, should be greater than 7. The movement of your lateral wall, big E prime, should be more than 10. And the ratio of the two should be less than 8, which is what equates approximately to your pulmonary capillary wedge pressure. So that's how we assess the ventricle. Eyeball is best. We can use EPS, we can use MAPSI, and we can use tissue Doppler. We can also measure stroke volume. In this case, we're going to use a thing called the velocity time integer. We're going to measure the blood using pulse wave that goes through the LVOT. To do this, we're going to go to a parasternal long axis. We're going to focus on the left ventricular outflow tract, and we're going to measure the size of the left ventricular outflow tract, and we're going to calculate the area of that cylinder, pi r squared. We're then going to take our pulse wave, but instead of looking at the mitral valve, we're going to look at the left ventricular outflow tract, and we're going to measure blood that moves through the valve at that point. We're going to put our cursor here about 3 to 5 millimeters before the aortic valve. And when we press the pulse wave, we're going to get a velocity time integer, so we can see opening aortic valve, closing aortic valve, and this is the mass of red cells being ejected through the valve. And we're going to trace the envelope around, and that tracing is called the VTI, velocity time integer, and it should be between 18 and 22. Most people with cardiac shock, it'll be 12, 13 or below. People with sepsis with high output will be 25, 30 or even more. Now, the cardiac skeleton's fixed, so most of us in fact don't use pi r squared, we don't measure the LVOT, we just say I'm only going to use the VTI, so I'm only going to do that pulse wave measurement because it's only that will change with fluid boluses. So we're going to give our fluid bolus, our 250 or 500 mils, or just do a passive leg raise before and after, and we're going to measure the VTI and see if it increases by more than 12 or less than 10%. And that will tell us if we've got a fluid responder or not. And I'm sure many of you out here are using this as part of your management. So the last part of the talk is, can we do this? Can we as intensivists, anaesthetists, emergency physicians perform this task? So I'm writing a meta-analysis systematic review of this at the moment. Our population is adults. Our intervention is transthoracic, echo, not TOE. Our comparison is non-specialist to specialist. We've defined a specialist as a cardiologist, completed training, a sonographer, completed a degree and signed off, or a non-cardiologist that's done a dedicated 2-year echo fellowship. So that's specialist. Non-specialist is everybody else. And our outcome is the comparison of systolic function by any means. We found there were 11 studies performed in the emergency department. One was published as an abstract only, but with sufficient data for analysis. There were over 2,000 patients, although 976 of those are from one large American retrospective study with numerous errors. 6 looked at EPS, 1 looked at Simpson, and 8 looked at eyeball. So of course several studies assessed more than one method. All compared by different statistical methods, which makes comparison and pooling difficult. The reference was very different in different studies. For the reference, some took a video. The video may have been taken by the emergency physician doing the test, or the cardiologist or a sonographer, and be reviewed by a gold standard of a sonographer or a cardiologist. Other reference standards may be the cardiologist did their own echo, but then it might be a few minutes after, it might be before, 4 hours afterwards, or in one study the next day. So there's a lot of variation in the way the reference standard was performed. The population studied may be ED, it may be ED shock, one study defined as below 100, 190. It may be patients presenting with dyspnea, or it may be a general convenient sample which most used. By that I mean, whenever the research team was there, they recruited patients. And it's not always clear why they recruited those patients. Half the studies just said because the clinician thought they needed an echo. And of course, our criteria may be quite different for whether you want an echo, you want an echo, or I want an echo. So we graded these using Quadras 2. green is good, yellow is I'm waiting to hear from the authors or I couldn't answer, red is trouble. Trouble here is usually because it's a convenient sample using a very small number of doctors. So you may have an ED of 50 doctors, but only 3 of them are in your trial. And those 3 often had special training before the trial in addition to their core training. So it makes it very difficult to generalise these findings to all of us sitting here. So the general agreement, however, was good. Eyeball gave a kappa on those studies that reported a kappa of 0.69, EPS a kappa of 0.77, VTI a kappa of 0.78, and regional wall motion abnormalities of 0.83. So we can conclude that in general the agreement between a cardiologist and a non-cardiologist to assess the ventricle by EPSS or eyeball, an eyeball that we're dividing the ventricle into hyperdynamic, normal, reduced or severely reduced function, which is what we need to guide our initial resuscitation. So this is not exact calculating of ejection fraction. So in summary, for your parasternal view, remember 3.5, 4.5, 5.5. Your aortic root should be 3.5 around, or upper limits of normal. Your atrial upper limits of normal around 4.5, and your ventricle 5.5. Your septum should be less than 13 millimeters, your left ventricular free wall less than 10. For your EPSS, if the mitral if the mitral valve is touching the septum, you've got normal function. If it's between 7 and, that should say 18 millimeters, you've got ejection fraction of 30 to 50%. If it's more than 18 millimeters, you've got severe dysfunction. In your lateral wall, remember SALPI, septum, anterior, lateral, posterior and inferior wall. And remember that each of those walls should improve in thickness by 50% or more. In your apical view, you can measure your left ventricular atrium, 5.5, left ventricular diameter 5.5, work out the area of your atria, should be less than 20. Put your tissue Doppler on the septal and lateral wall, measure your S wave, E wave and A wave, and if you want to, you can also look at your MAPSI using M mode, and you should see greater than 12 millimeters at the septum and the lateral wall. So I'd like to thank you very much for your time and attention. Do we do questions now or later?
We can do one question and then we need to move on, otherwise we'll be late. Yep.
Great talk. If you remember, probably 30 years ago, ECGs, 12-lead ECGs, the idea that a computer could interpret an ECG. It could read rhythm, it could look for ischemia or injury. You know, we take it for granted now, and the less experienced still tend to rely on the computer versus a more experienced person interpreting the actual data. So we see Echo, Butterfly now has AI technology where it does the interpretation. So, you know, we talk about eyeballs and all these measurements. Now the computer will tell you whether you have an optimal image, and then it will tell you ejection fractions through its algorithms. Where do you see that going as far as an inexperienced operator and relying on, you know, just AI rather than a large N?
I think that's a great question, and I'm sure it's the future. How far away that future is, I'm not sure. I've played with the Butterfly, I've played with a number of others, and I'm advising in a completely non-financial way some friends that are setting up a business to do this based in Singapore. The problem for AI is the same as the problem for us. So if you're going to estimate an ejection fraction, you're looking for movement of that wall, and the difficulty is defining where that wall is and knowing if your image is on axis. So are you crossing the ventricle like this or like this? And at the moment, I've not met an AI system that is good at determining if the image is of sufficient quality, is on axis, and really drawing out that wall. And that's the skill that makes a cardiologist so much better than us, because these, as you go from movie to still, the wall does look a little different, and exactly where you define the edge of the wall, because it's not it's usually a greying out, because there is movement between each of those boxes, as your videos are broken down. So I think it's a really good thing. I think it's probably going to be the single most important step in making echo a generalizable tool like the ECG. I'm just not sure how far it's got. The butterfly stuff has been okay, and I don't think it performs that well. The group in Singapore, I think, are performing a little better, but I know they're a long way off from putting this in the marketplace. What's your thoughts? Are you using that?
I've just been playing with it, and they're actually pretty smart. I found it's very difficult, even on a young, healthy patient with very normal anatomy, to get an because the computer won't, well, the butterfly will not interpret it unless it feels it has an adequate image. And to get that adequate image is very difficult, even for an experienced sonographer. So I think they're being cautious with the technology. They're not just, it's not just throwing out an ejection fraction on every patient you put a probe on. So I think they're being appropriately cautious.
Yeah, and it's sensible, isn't it? It'll evolve over these years.
Well,
Thank you.
Thank you so much, and that's a fantastic talk. So we're moving from the diagnostic to the practical a bit more now. So our next speaker is Pilasi Menichetti. He's a trauma surgeon at one of Europe's largest major trauma centres at St George's in south west London. Now, I think the stuff we bring him at St George's is kind of extreme, and the stuff that they do at St George's is kind of extreme. But actually, not only is he a trauma surgeon within the major trauma system in a first world country, he's also a Médecins Sans Frontières and humanitarian doctor, and has done surgery around the world.
Right.
And in keeping with the spirit of this conference, I think it's going to be really interesting to hear some of his thoughts about doing extreme surgery in extreme settings.
All right, thank you very much to the organizers for having me here. And I would like to take you now to a different place for probably to expand where we can work actually. Despite that I work for MSF, these views are my own, and I do not represent them in this talk. This is not working. No? All right, so what I'm going to tell you now in a few seconds is what would be probably the difference that you would experience if you decide to volunteer or work in any of these kind of organizations, non-governmental organizations, or even maybe you have been joining some other kind of agencies to bring your expertise and help and knowledge to different regions where it's quite needed. That's right. So defining what is extreme, I had some trouble to define what is extreme. What might be something extreme for me might not be for you. So I just tried to put on what I felt was challenging for me when I was in these kind of contexts. I've worked in all 5 continents, and the cultures and the difference are so broad that really what you can experience, it varies a lot. So I try to just put them into 6 different areas, and we're gonna try to go through once the slides are on. All right. Yeah, I can sing if you want. No. Yeah. Perfect. All right. So I told you that I came up with these. That is not evidence-based. It's just my own trying to put things together on these 6 areas. I'm going to go one by one. So the first one that you might consider what is like extreme would be the context. So I'll take you to where you're deployed as a trauma surgeon, emergency surgeon, or ED physician, or intensivist anesthetist. You would come to these places with actually lots of destruction, lots of needs, lots of people, blockage, lack of electricity, lack of water, sanitation, and wounded people and sick people that had nothing to do with that, but they were just sick, and it happens to be that the hospital has been destroyed. The other big group would be the armed conflicts, where it's similar in terms of the destruction. Sometimes it's bigger. The difference is that it's not a one-off, but it's a repeated kind of sudden onset. You have an earthquake, you have one, and here it's like you have the exact same patterns going to be repeated, sometimes daily or sometimes weekly. So these happens to happen in these areas, which you can see the darkest. Actually, these, you've seen probably this map, which is not intended to tell you where the conflict zones are or the natural disasters are. Actually, this is to show you where is the people with less access to safe surgery and anesthesia. So the darker the red, the less access you have. So probably from the 300 or more than 300 million surgical procedures done worldwide, just 6% are into these areas. That these areas actually represent 1/3 of the population. So it is important because they're overlap, so they have already trouble, and on top of that we add on like an armed conflict or a natural disaster, and that takes us to know what is, it's just a reminder of what is global health and why is it needed. And probably better than me is going to be this Lancet video that is going to tell you why are we looking at that. This needs some volume.
Over the past 2 decades, global health has focused on individual diseases. Surgical care has been afforded low priority in the world's poorest regions, leaving 5 billion people without access to safe, affordable surgical and anesthesia care. Patients requiring surgical treatment will face multiple hurdles: delay in seeking care, delay in reaching care, delay in receiving care. Reaching the hospital does not guarantee treatment, as many lack the proper infrastructure to provide emergency surgical care. As a result, many easily treatable conditions become diseases with high fatality rates. As many as 90% of maternal deaths could be averted by timely intervention. For those who successfully obtain treatment, 1/4 will experience financial catastrophe as a result of receiving surgical care. To save lives and prevent disability, an additional 143 million surgical procedures are required annually in developing countries. Today's surgical workforce would need to double in 15 years to reach our target of 80% coverage of timely access to essential services by 2030. The total costs required to reach these targets are significant, at approximately $350 billion by 2030. However, the costs of failure are even greater. The lost output will cost developing countries an estimated $12.3 trillion. Investing in surgical services is affordable, saves lives, and promotes economic growth, making surgery an indivisible, indispensable part of healthcare.
If you want further information, you can visit that site. So this is where we will be working at, to be the conditions of that specific country or place. But then you will be placed into a tent, a shared place, or a shelter or something where you would be struggling or facing differences on what you're used to normal living. So some people would find it very stressful to have to share every space with other people. Some other people felt the contrary. They felt like despite being surrounded by a lot of people, they feel quite lonely. So that living conditions can affect and can be quite extreme if you're not used to that one. Of course, there's the climate differences. It can be, you can be in quite extremes if you're in the desert, and the safety, which is another one. It's like here we are in Iraq, and where it was quite hot, but also we had no access to to outside the compound, which is actually feeling of being already all the time closed. But that's needed because there's safety issues, and even though there are regulations and conventions that where hospitals cannot be bombed, in 2015 this hospital in Afghanistan was bombed by, and we MSF received an apology from President Obama because their military bombed by accident our hospital, killing all the patients and doctors present that day. So that is something real. Despite this convention, not everybody follow them, but sometimes something can be more unexpected. So in the same place in Iraq, we started receiving patients with these injuries, and you know that in these wars has some rules, but they're not always followed. So this was not supposed to be used, but chemical weapons were a threat, a real threat, which makes you take some extra precautions. So in being in this very hot weather can make it very difficult to work with. Some people would say, well, then it's like being in military. Well, actually, it's not quite. So military surgery or military medicine and humanitarian medicine has two different approaches. So humanitarian would be focusing on doing most for the most, whilst military would be no man left behind and trying to have zero preventable mortality. So if you, on the experiences of previous wars, so the results from the military from the US on these patients showed that the survival rates were comparable to motor vehicle accidents in North America. So actually that is the standard that they would expect for those conflicts, but that's not translatable if you're going with a humanitarian organization. So the military and NATO and the coalition has developed this kind of echelon that probably you are familiar with, where they have like a very clear steps on what you're going to do from the casualty. So the patient's going to be injured here, you have an hour, you're going to get damage control surgery. In 2 days you're going to be for the definitive surgery, moved into Germany, and then back into your own country for rehab. Well, in limited resource countries, that whole chain of treatment is not really under our control. We have problems with the resources. So this is where I work in London. I'm a consultant surgeon in one of the trauma centers in London, but this is where we work when we go with MSF. So it's in a tent, and here we were in Yemen, and 2 surgeons and 2 anesthetists, and we're just covering full-on shift, and we were the only hospital. We were there because there was no hospital in that area in the north of Yemen, and we were expected to do all the surgery that came from the door. And that's, you might feel that could be okay because it's what you do at home, but there is some difference that you need to be aware of, and some of them are the clinical conditions that may vary. So it's like, oh, an appendicitis here and everywhere. Well, actually it's not, because we would normally see the patients that I operate for appendicitis in London would probably had some pain 5 hours, 12 hours, maybe a day before. These patients would come a week, 2 weeks, even more, septic, peri-arrest, and just for an appendicitis. So they would have a very late presentation. That is very important especially for trauma, and especially also because sometimes, because we do not control this chain of care, the previous step maybe was suboptimal in terms of management, and you would have to deal with that. And you also have to be aware of the local epidemiology, and I will show you some examples of that. So these ideal chain of care from where the injury happened to rehab, it's actually not translatable. And why is that? Just focus on the first hour, where we know that in trauma that it's quite good for prognosis. So if you do good interventions as early as possible, you might have better results. So these people have the military, their colleagues would be trained so they can provide to their colleague soldier some first aids, and they would carry some things. The patient we receive, the civilians, would actually come whatever way they can do that. So they would do their best to try to drag them into the hospital, but that would be maybe putting them into a truck without having, you see this patient is bleeding, no pressure, no stop the bleeding consciousness of the population, and they would try to just take the patient as quick as possible. But as you can see there, this patient had some dressing there, but it's clearly bleeding from the abdomen, so probably that would not be doing much. Sometimes they do not use the ambulances because the ambulances are used for something else, like for transportation of some things. Sometimes they cannot use the ambulances because they have been targeted as well. So sometimes they use the ambulance just as a taxi. So in this place, we were again in Iraq, so they brought in this patient that was injured, gunshot in the leg, on the thigh, and this patient, as you can see, was bleeding. Look at how wide this leg was. So he was put into the ambulance. That was like just immobilized, but he had no IV fluids. No one was stopping there. Patient arrived, peri-arrest, arrested on arrival, and died. So we know that these the patients on war injuries, they would be mainly due to bleeding, and the ones that would concentrate the mortality is going to be the ones that are not compressibles, and those are the ones that would need surgery. Therefore, we need these patients quick, but we need to do something in between. Start resuscitating, start stopping the bleed that you can, and then we can do damage control. So if it's a vascular and orthopedic injury combined, maybe just a shunt and then the patient do an X-fix and send the patient across. Do a damage control surgery focusing on stopping bleeding first and limiting contamination second. And as I mentioned, some other things might happen, because like a spleen injury, okay, that's the same in London or in Congo. Well, actually not, because there are some differences locally, like tropical spleens, where you can have a spleen that is occupying the whole left side of your abdomen, or you might have worms or HIV or other things that you need to be aware of. So this is with one single patient. If you have multiple patients, then it comes even more complicated. I'm not going to get into the triage because you've seen that on our simulation with VR. But I just want to call your attention of these things. How patients come. When you come after an earthquake, what I'm going to have the first day? Well, it comes into this curve. So the first one is going to be the ones that are going to die without intervention. If this one, unless you know when this earthquake is going to happen, you would not be here to treat these people. So you probably arrived around here. So this is locally, depending on the local resources. There's nothing you can do to intervene there. So why this curve is not going flat down, and it's just having this extra, is because you would have here all these non-immediate life-threatening injuries, mainly on the limbs, but also other emergencies that would come, like abdominal cases and C-sections. These are the ones that are going to be related to infectious diseases. For internally displaced patients, are going to start building up. Non-communicable diseases and mental health, and then all the people that you were supposed to be operating elective that have been suspended. So basically, these are going to be where you can start the people that you would be expected to treat. So, and what kind of surgeries you'll be doing? You'll be doing trauma, emergency surgery, and C-sections. I'm saying C-sections just to simplify, but obstetric emergencies. And you're supposed then to know all these. Normally we're not trained to do all these things, and even though this is the most common operation in the world, might not be the most common operation for you. And if you see this graph actually overlaps with the previous one, this is maternal mortality. So it's the same place where you're working that as well, they would have the highest maternal mortality. If you see the causes why these people die, it will be here you have all the causes. If you concentrate only on the direct causes, by doing C-section and knowing how to treat surgically postpartum hemorrhage, you would be treating 72% of the direct causes. So we have limited resources. We need to be trained for that, but we also need to be creative. So this is a good way to give warm blood. If we don't have the fancy great tool that you've seen there, this is a good one. And also to do back dressings with your vacuum, with your suction. That was in Central African Republic. So, but you need to really be prepared, and for that we're trying to get into trainings, but they have costs. They have difficulties for people to get into these trainings because they're done, for example, this one, which is, I think, is the best course now for training or preparing you to go to these places, which is the STATE course, so the surgical training for severe environments, done in London by the Royal College, and we teach these twice a year. So people can apply to that one, and David Nutt Foundation that you've seen in the workshop, what's the job they do? They would give scholars to people to get trained in the UK, and through a scholarship. they'll be quite happy with that. But if that is not possible, and because we have limited numbers, when we can take these courses to their places, and we do that by delivering this mannequin, which is fantastic, where you can show the different surgical procedures, and then simulate obstetrics, all the emergencies I've just mentioned, and then they can have a go and doing hands-on stuff with these different models. So if you know about someone that would be interested in doing that, or to a place where you would need that course to be sent to, just apply directly to the David Nutt Foundation. So I'm mentioning that this because maybe this looks quite far to you, but I was on the consultant on call for when the London Bridge attack happened. So I was scared. This was new for me because I was not. When I go to the war, I know that I'm going to the war, but I was not expecting the war to come where I was working in London. And actually, it looked like a war zone. So you never know, and it's better to be prepared. I think we have to do the best for what we can, and to be, ready for our circumstances that now are being more frequent, unfortunately. And I hope this could inspire you just to think a bit out of the box, and it's like the world is slightly bigger, and that we can do some changes. Thank you very much. Thank you.
Thank you. An amazing talk, and I have to say, from my personal experience, what you guys did on the night of London Bridge was absolutely brilliant. I don't think the patients could have asked for more. Any questions? Okay, well, I've got one. So, a lot of young and aspiring people in the room here wanting to get involved in emergency and critical care fields. What's the best way now, with the way that medical training is very channeled into specific specialties? And as you say, a younger surgeon than you, not saying that you're old, but a younger surgeon than you might not have the breadth of clinical experience. So what would you say to the young people in this room? How do they get that breadth of experience?
Yep. So it has two components. So what is good for you, and what is good for the patients there. So if you can go there and I'll learn by doing, that actually not accepted in ethically. And in MSF, for example, you would not be taken unless you're a consultant level and that you know the procedures that you're expecting to be doing. So you're going to give a list, and there would be, are you ready to do this and that? So that applies as well for intensivists and anesthesia, anesthesiologists and ED doctors. So they would ask you specific procedures. So you might, because today is if I get one of my junior registrars, they would be very comfortable doing laparoscopic, and if I tell them, okay, convert that appendix to an open one, they would freak out. So that is going to be, so it's a completely different thing that you'll be doing in the other place. So you have to, probably these kind of courses would help to prepare you, and then going with a mentor on your first mission, so you feel it's an easier, smoother path to a different reality, and all these challenges that would go. So I would not advise you to join these independent groups that go we're going to try to save the world without support, because you really need a big support behind. So I'd rather advise you to join big agencies and all the preparation that they would suggest.
Thank you so much.
Thank you.
Absolutely brilliant. So we move from